Thank you, Wayne Cooper. We got your message as well. Okay, so my name is LJ Stambuk. I'm the presidency of the World Affairs Council of Charlotte. I would like to welcome you to today's World Affairs Council digital programming. As many companies, businesses, nonprofits, we are reverting to having our programs delivered to our members and supporters digitally. Please follow us every Wednesday. We have a weekly update on all the upcoming programs of the World Affairs Council, interesting data, information that we would like you to follow and be involved with the World Affairs Council as you go. From ancient times, doctors and healers and shamans were revered by their communities. We live in extraordinary times, extraordinary times. This is happening for the first time, a global pandemic in most of our lifetimes. And it's truly a global pandemic. There are only 4 nations, 4 tiny island nations that have not yet reported the pandemic. But the pandemic is so widespread that even today, Saudi Arabia announced that they're stopping the conflict in Yemen because of fears of the coronavirus. We have in our community people who are out there in the first line fighting the disease, protecting our families and our community. We're very, very grateful to all our doctors, all our nurses, all our health workers from Atrium Health and other health organizations that are actually working to protect us and to diminish the lethal effects of this horrible, horrible disease. Today we have with us, and I will read, an extraordinary person, a World Affairs Council board member, Dr. David Callaway, who's a professor of emergency medicine, Atrium Health in Charlotte, North Carolina, where he is the chief of disaster medicine in the Department of Emergency Medicine. Dr. Callaway is a Navy veteran who served with the United States Marine Corps in Iraq, Burma, and El Salvador. He is the father of Elizabeth and Liliana, 2 princess warriors, and husband of Dr. Jennifer Callaway. He has an unrelenting drive to improve his community and a healthy state for the status quo. Dr. Callaway subscribes to the idea that crisis offers opportunity. As an Eisenhower Fellow in 2014, he investigated the health and security impact of Syrian refugees on Jordanian civil society. Currently, he's working to mobilize U.S. combat veterans to engage in community service projects focused on social justice. David's extensive work in health and crisis recently led to his appointment as Chief Medical Officer for Team Rubicon and is a live member of the Council on Foreign Relations. Currently, Dr. Callaway leads the Emergency Medicine COVID-19 Nerve Center and is involved in all Atrium Health's crisis surge capacity planning. We are delighted to have Dr. Callaway with us today, but before I turn to him, I have 2 announcements to make. One, please go to atriumhealth.org/coronavirus. It has updated and free online COVID-19 assessments and all kind of information that you might find useful and necessary at this time. Dr. Derek Raghavan, who cannot be with us today, did want me to say this before you start. I'm sure you're going to address that. He's asking everyone on this program today joining us to keep their social distance. He says that is the most important thing that we can do and contribute to combating the coronavirus. So without further ado, Dr. David Callaway, thank you.
Thanks, LJ. I appreciate it. Are you capturing my audio all right?
I am. Everyone else?
Okay. I'm going to try to share my screen here because you're
the only one on the screen, David.
I don't know. Great. Can you see? All right. Do you see that?
We see the disclaimer.
LJ, are you able to see the?
Yes.
Okay, great. So, as a professor, I am intimately tied to PowerPoint, unfortunately, everyone. But thank you, LJ, and thanks to the staff of World Affairs Council of Charlotte. What a great team. And thank you to all the supporters of the World Affairs Council in general and those joining us today. I'm not going to go through my background. LJ did it well, but basically my job is to run the crisis response when a situation overwhelms our crisis response teams. So as we talk about the COVID pandemic, I just wanted to start by saying, in a moment of vulnerability, this is the hardest thing that I think I've ever done in my life for a variety of reasons, and I'm sure that'll come out in our Q&A. But as we have a conversation for maybe the next 20 or 30 minutes, I'd like you to consider 3 questions that will frame how we approach this issue. The first is, what does this pandemic mean for the future of our nation and our role in the world? The second is, what does it mean for the future of healthcare? And I'll talk a little bit about what we're doing at Atrium Health. And then finally is, what does it mean for our communities and our families, and what can we do to take action? So, got to give you the update because I'm a doctor, right? I have to do this. So the coronavirus, the novel coronavirus is a beta coronavirus. It was first described in Wuhan, China, after a case of several pneumonias popped up and they weren't quite sure what was causing it. It's the same family as SARS and MERS, and it's the same family as the common cold. Apparently my internet is unstable, so hopefully you can all hear me. It's transmitted person to person, usually and primarily by respiratory droplets. And this goes to Dr. Raghavan's comment that it's important to stay away from people who are sick. The incubation period is 2 to 14 days. 80% of cases are mild. 15% are serious, meaning they require hospitalization and things like oxygen and IV fluid. And 5% end up in the ICU, usually on a ventilator. These people who end up on a ventilator stay on a ventilator for 2 or 3 weeks, and about half of them die. And this is critically important because this is what's happening across our nation in our ICUs and in our hospitals. And this is why there is such a challenge in how we respond. So, in my opinion, the COVID-19 pandemic is the most complex existential threat from a national security standpoint that we have seen in our lifetime. And I put this in comparison to World War II and the Cold War, the Civil Rights Movement, and absolutely in comparison to terrorism. Now, I don't mean coronavirus is going to kill everyone. It's a serious disease and it's got a direct mortality of 1 to 3%. And it's got an unknown impact on mortality as we go down the road based upon its impact on the health system. It's bad, but it's not going to kill everyone. What I mean by the existential threat of the pandemic is, just like those before it, it's accelerating our crash course towards a reckoning on who we are as Americans and the role we'll play in the world. In the US, we have plans and processes on how to respond to a pandemic. They're rolled into what's called the National Response Framework. We have trained them and we understand the broad consequences of a pandemic. So the statement that, quote, no one could have predicted this, end quote, is patently false. We predicted this for decades. In 2005, under President Bush, we had our national strategy for pandemic influenza. And from that report, which was one of the first that I cut my teeth on when I started doing disaster medicine, is a line. The pandemic or worldwide outbreak of a new influenza virus can overwhelm our health and medical capabilities, potentially resulting in hundreds of thousands of deaths, millions of hospitalizations, and hundreds of billions of dollars in direct and indirect costs. So we know that this is a threat, and we've known it for a while. And we have plans in place on how to respond to this. We know that the response must be rapid. It must be a whole of government response with federal, state, and local governments taking action supported by both the private sector and our citizens. It cannot be rolled out 2 months into the crisis, and it cannot be rolled out in a haphazard fashion. I'm not getting political because I'm a registered independent and I've served under presidents from both parties, but what we have seen in this rollout is damaging. We have chosen over the last 20 years not to fund the pillars of our response framework. We have a plan, but we haven't actually built a way of executing it effectively. We've cut funding to the CDC, to the Infectious Disease Rapid Response Reserve, and our global development and diplomacy efforts that are required to respond to a global threat like the COVID pandemic. And what we're seeing now is a consequence of many years of neglect of these systems and an acceleration of outright attacks on our core institutions. So what does this mean for our nation? And I told you we talk about our nation, our healthcare system, and our communities, but I have three thoughts about what this means to our nation, and there are a lot, but just to open up the conversation. Number one is philosophically, we must decide about our relationship with facts and the truth. There are not alternative facts here. There is fake news, and that's called propaganda. So Dr. Oz and Rudy Giuliani, and unfortunately the president has even succumbed to this, are fueling some of the misinformation around this disease, which is directly increasing its deadliness. Quote, anyone can get a test if they want it, end quote. Patently false. Hydroxychloroquine is a strong, powerful drug, but it doesn't kill people. Patently false. The FDA has approved hydroxychloroquine for treatment of COVID. Also not true. In war and in pandemics, truth and facts actually matter. And the abuse of truth and facts is a known technique for winning wars and ruining countries in pandemics. So the truth matters. Number two, we must decide what we value as a society. People, communities, the almighty dollar. Where we fall on this spectrum will change after this pandemic, and we as a society need to figure that out. According to Forbes, by next week, the 2-week total for unemployment benefit applications will top 6 million. The expected second quarter GDP on the US is down 13%. With our massive wealth disparities prior to this pandemic, what are we going to choose to do as a society as we recover? And you may ask, why is a doctor talking about this? And I'm talking about it, one, because I'm a citizen, but two, because this affects how we provide care. 20% of our GDP is related to the healthcare industry. This matters. And finally, perhaps more controversially, which will tie into the next phase, we must acknowledge that we're on wartime footing. Now, the press and our government and politicians in general may be prone to hyperbole. I'm generally not. I believe that we are in a war against COVID, and it's not an ethereal war like the war on drugs or the war on terror. I believe that we're at war against a discrete living organism that's already killed 15,000 Americans, 4 times as many as died on 9/11, and we haven't seen the peak yet. I believe that we're at war because the consequences of this organism attacking our viability and threatening our way of life. Restaurants are shuttered and freedom of movement is restricted. I'm not sure that any terrorist attack or naval blockade has had a similar impact on our country. I believe that we need to approach this from a wartime setting because in order to succeed now, we need to mobilize the vast resources of our public and private sector in a coordinated manner in order for our country to survive. And I believe that we need to change our mindset. So as in combat, we must acknowledge that we need coherent leadership. We need to rapidly identify threats, be they disinformation, loss of a workforce, loneliness, and we need to be aggressive about seeking this data and this intelligence in order to understand the problem and deploy adaptive leadership in the solution. Most importantly, we must act boldly in the service of our country. But perhaps most critically, we need to understand, sorry about that, we need to understand that if we define this as a war, those of us, especially who have been in war before, can proactively acknowledge and wisely account for all the implications and danger of a wartime America. There are many who don't think we should call this a war, and I respect that. We know that in times of war, we can see the best of our warriors and our citizens, but we must recognize that war is scary and that this fear can sometimes inspire bold actions that are counter to our nation's interests. We've seen this with some of the white supremacist movements in our country over the last few weeks. If we're not intentional and clear-eyed in our response, we can fall prey to xenophobia, selfishness, hysteria, and we can see our society unravel. And we're seeing these challenges today. Our considerations must remain focused on protecting our electoral process, respecting our laws, holding leaders accountable, supporting free press, and defending the most vulnerable in our society. We cannot let the fact that there's a pandemic going on distract us from the fact that the rest of life is still going on as well. If we're not careful, measures that are meant to protect us can become measures that are meant to silence us. And I know that this is controversial, and I'm looking forward to talking about this at the end. So the doc is done talking about national security and recovery. Let's get to healthcare. So what does the pandemic mean for healthcare, and what are we doing at Atrium? So to date, we have 400,000 or so documented cases of COVID in the United States with about 15,000 deaths. What's important is the graph that you're seeing right now is from 2 days ago, and this is today. So 4,000 more deaths and a dramatic increase in the number of cases. You could calculate a mortality rate from these numbers, but it will be wrong, partially because of our incoherent testing strategy rolled out in the United States, but partially because we have no idea how many people are infected and not showing symptoms. The fact is, it's a serious disease, lots of people are dying, and healthcare systems are being driven to the brink of insolvency as we prepare for this massive response. Now, the death toll is dominating the headlines, and it's important because that's the human story, that's the face of it right now. But if you dig beyond the tweets and the 24-hour news cycle, you'll find some deeper seismic shifts going on in the healthcare industry. Some are good and some are frightening. On the frightening side, the epidemic could cost Medicare between $38 and $115 billion this year. Rural facilities and critical access hospitals across the state of North Carolina are seeing 40 to 60% decreases in volume. And because of that, they're laying off staff and shuttering their doors. At the same time, the crisis has lowered the barrier to entry for many technological advances: digital medicine, artificial intelligence, home virtual care. These innovations were once luxuries and novelties, and now they're a critical aspect of our response today, but also setting the stage for the future of healthcare so we can deliver more personalized care and better value to our patients. Keep mixing up my screens here. So what are we doing at Atrium? There's a very real operational question, and it is, how does a health system prepare for the potentially devastating onslaught of a pandemic while remaining solvent and ability to achieve its daily mission of taking care of patients? The 20th Secretary of Health and Human Services, Michael Levitt, in 2007 said, "Everything we do before a pandemic will be alarmist, and everything we do after will seem inadequate." This is a real challenge as we try to address this problem. At Atrium, our blue sky mission is to improve health, elevate hope, and advance healing for all. And our vision is to be the first and best choice for care. Fortunately, our leadership recognized early that this pandemic was going to change healthcare forever. And this simple acknowledgement allowed us to evolve how we lead in the industry. We understood that the only way to combat a pandemic is through a broad-based, multi-stakeholder collaborative approach. But for any of you on the line today who've ever been involved in a quote-unquote broad-based, multi-stakeholder collaborative approach, you understand the total goat rodeo that these can become. So initially, we stood up the crisis response model that we knew, and this is called the incident command system. So the first week of March, we activated our incident command structure, and you can see what this looks like. It was created in 1968 to assist with coordination of wildland fire response, and it creates an almost dogmatic process for reporting and roles and responsibilities and span of control. It is awesome when you respond to a fixed event like a hurricane, and if we deploy Med1 to the coast, because it allows us to integrate from around the country in a manner that creates standardized language and workflow for everybody. It is not awesome if you're trying to address a dynamic threat. It is not a nimble system, and when you're facing a networked problem like a pandemic, with data that one day says you'll be 2,000 beds short in your system, and the next day says you'll have a 4,000 bed surplus, you have to have a more adaptive approach to solving the problem set. So many of us who study adaptive leadership, and especially within the veteran community, realize that COVID-19 was a different sort of crisis than anything we had faced domestically before. But we saw the immediate parallel to the way the Joint Special Operations Command and General McChrystal battled al-Qaeda in Iraq. This team of team concept that they created is how we modeled our response. JSOC was a regimented bureaucracy that was highly organized and efficient, but they were not nimble and they could not adjust as quickly as Al-Qaeda. The result was they were losing the war. We recognized that we were seeing the same thing here with COVID. And this was JSOC's initial command structure. They moved to a command of teams and then to this team of teams concept. For us, we were able to begin deploying and executing a hybrid team of teams model that leveraged both the efficiencies of scale of a $14 billion healthcare bureaucracy while also creating a dynamic, adaptive leadership team to address the COVID threat. So the first thing we did was establish a nerve center that fed into our incident command, and we refocused on 3 key priorities: protecting our patients, protecting our staff, and protecting our community. We then created a series of cross-disciplinary and cross-functional task forces that were able to execute against priorities. And we were able to cram in 5 years worth of change and 5 years worth of evolution into about 6 weeks. So that sounds pretty dramatic, but what did our teams actually do? So within the realm of protecting our patients, one of the first and most impactful actions was to voluntarily cancel all elective procedures and surgeries. Now you can imagine the complexity and the angst involved in turning off a key financial driver of a health system. But our cross-functional teams, because they had the right representation and access to the right data, were able to build the right models both on a technical and an ethical standpoint, and they were able to align them against our core vision. This move immediately created space within our systems to take care of critically ill patients. Our task force has also leveraged virtual care capabilities like never before, and at the system level, increased the volume within some service lines by as much as 20 times. And this is virtual care at home, virtual care in the emergency department. It allowed us not only to protect our staff by reducing their exposure to COVID patients, it allowed us to put quarantined health workers back to work while they're not on the fixed facility. We launched the new Atrium COVID virtual hospital that enables us to care for hundreds of patients at a time while they remain in the comfort of their own home. And in doing so, freeing up some of our space at hospitals. We set up mobile testing sites around the community in order to test people in their cars and keep them out of hospitals. But understanding that none of that was enough, we recognized that if we saw surges like we do in Colorado and New Orleans and New York, we had to do more. And so we created an additional 2,000 beds on our acute care campuses, including 700 ICU beds. This is a massive investment in our community and in our response capabilities. Our next priority, after protecting our patients, is protecting our staff. And let me tell you that this has been a tremendous challenge as we work through some of the confusion of the government response. So we focused on ensuring that our teammates, who really we consider our family, are able to be safe, feel safe, and can care for our community members. Our focus was on providing a safe workspace, ensuring financial stability, and then mitigating the impact on families. The acquisition of personal protective equipment, N95 masks, the PAPR masks, the Tyvek suits that you see on TV, this has been one of our biggest focuses and struggles over the last 6 weeks. We've been fighting since the beginning to leverage our private appeal to support through the strategic national stockpile, and leverage an amazing base of donors to make sure that we have the personal protective equipment that our teams need. But like many systems and states, the chaotic federal response has made this challenging. I don't know if any of you heard Governor Cuomo on NPR a few days ago, but he described this free-for-all bidding war that is now going on between private health systems, states, and FEMA that have basically driven up the cost of all of the ventilators and the personal protective equipment in the world. This has been an amazing thing to watch from a standpoint of operational complexity. And it is one of the things that has stressed our system the most. The good news is that necessity is the mother of innovation and invention. And our teams were not willing to stand by and wait for equipment. So while we continue to aggressively pursue personal protective equipment through contracts and government processes, our teams began overcoming these challenges by developing methods to decontaminate single-use N95 masks so they could be reused throughout the day. They also began engaging community partners to do things like 3D print face shields. In addition to making sure that our staff are safe at work, our leadership committed early on to ensuring that salaries and job security for our team were put in place. And they created a unique redistribution program so that our teammates that saw less work right now could be put to work in other areas across the system, so that instead of being laid off, they actually could maintain their salary and their benefits. And this is, again, a tremendous commitment to our community. I know health systems all over the country, and they are laying off doctors, nurses, secretaries, and support staff left and right. And the fact that we've made this commitment to do our best to keep people on, even as volumes are decreasing, truly is reflective of our values as an organization. So what can we do to protect our community? From the community standpoint, we understand that messaging is key here. And again, going back to Dr. Raghavan's comments, the most important thing that you can do is good at the basics. And it's hard to do that when there's a tsunami of information out there. And the deadliest part of a tsunami is not just the volume of water, but all the contamination and debris that get thrown into it. So understanding that messaging is critical, Atrium Health invested heavily in supporting the county and state public health messaging efforts, conducting direct outreach to over 6 million of our patients with prevention tips and guidance on how to get care. We mobilized social media resources in order to promote the stay-at-home message. And in partnership with Microsoft, we launched a health bot on our website that LJ was talking about, so that people can both go through a mini triage to understand their symptoms and then get directed to the appropriate level of care. So the health system has seen a dramatic impact and will be fundamentally redesigned and changed after this pandemic. And what does the pandemic mean for our communities, and what will be the new normal? This is on a lot of people's minds. And I don't know that I have the answer to it, but I have a few thoughts. In general, I believe that we have the opportunity to shape our future or to be shackled by it. And prior to COVID, Americans were roundly seen as redirecting inward. We're abandoning key alliances internationally in leadership roles in global problems like climate change. We're becoming more tribal, even on the domestic level. And frequently I would see people defining ourselves more and more by irrelevant, hyper-specific taglines. And so social media and technology accelerated much of that descent. But COVID and the COVID pandemic offered us an opportunity to pause and reflect and reconnect, and even look at all of these social media and technology tools that previously were distractions, and now are actually tools that can truly unite us again. My wife, for example, is a physician, and many of you know her, and she went from taking care of complex wound care patients to homeschooling our daughters basically overnight. She had to go from taking care of patients to creating lesson plans and spending 14 hours a day with our beautiful, sweet, caring little devil children. And she's had to do that for the last month. And setting aside the mental health challenges of spending that much time with a 5- and 7-year-old, our 5-year-old down is learning how to read, and our 7-year-old is speaking Spanish better than ever. The bonds within our family have deepened, and we're figuring out new ways to connect virtually and more intentionally with all of our family and friends around the country. But we have it lucky. We have that opportunity that we can do work from home, and that we have access to the internet, and we have access to a support network. The question is, during this crisis, will we only look out for our own survival, or will we unite as a community for the good of our nation? And this is the opportunity that we have, I think, as a society. So the final closing is, what can you do? And I get this question asked to me a lot. And here are a few thoughts. First is do the 5. And Dr. Raghavan talked about this, but Michael Jordan, famously said, it's all about the fundamentals. And if you have the fundamentals down, then you can become great. So how do you slow the spread of coronavirus? How do you flatten that curve? Wash your hands, 20 seconds at a time. Different songs you can sing while you're washing your hands. Cough into your elbow. Don't touch your face. Stay more than 3 to 6 feet away from people, and stay home if you're sick. There's a big effort within Mecklenburg County and around the country to stay home, and that's great. That is important. The way that the disease spreads is by close contact with someone who's sick. So do the 5. What else can you do? Stay home and be smart when you go out. If you go outside, it's fine. Get a walk, get some fresh air, walk, but don't congregate in big groups of people. Be kind to each other. Be kind to yourself. It is emotionally and psychologically massively straining to stay at home all the time and have your life fundamentally change. It's okay to be kind to yourself, to take time out and to do something good for yourself and to do something good for your neighbors. Take this opportunity to do it. And then finally, even though we talk about using technology to reconnect, take a moment to disconnect from the news. Take a moment to reconnect with your loved ones and use this opportunity to help our community emerge stronger. So that'll stop. I'm looking forward to taking any questions, and thank you again for the time.
Thank you so very much. Thank you so very much, Dr. Callaway. This was just amazing. And we're, again, I have to say, fortunate to have you in our midst and people like you and all the healthcare workers we have in our community. So now we're open for question and answers. Jesse will lead that. I understand the technology is there for you to type in your question. Please do so. And can you see those questions, by the way, David?
I can, and I'm happy to just go down them if you'd like.
Yes, can you read them out so everyone can hear
Yep.
them? And then
Absolutely.
Thank you.
All right. Anonymous attendee, you're welcome. Stephanie Henricks, can you share more about Charlotte area and the current situation? How many cases are we seeing currently and in comparison with the rest of the state and the country, et cetera? Absolutely. So let me pull up my notes from this morning if I can get them. Hold on, just so I can give you an accurate number here. I might have to lie to you, I have too many notes. Generally where we are compared to the state. So Charlotte, Mecklenburg County is sort of the epicenter in the state, and you would expect that because we're one of the more urban areas. Where we are in terms of total patients is we have a couple hundred positives, and then we have less than 100 admitted, and then somewhere in the order of 30 to 50 in the ICU. There have been, I believe, between 6 and 10 deaths in Mecklenburg. From a preparedness standpoint, we are far ahead of anyone in the country, I would say. And part of the advantage is because we've done the social distancing and the stay-at-home initiatives, we have seen that famous curve that everyone knows now. That curve has been squashed down. And when it gets squashed down, the important thing to note is the total number of cases don't decrease, it just gets spread out. And so it allows us to allocate healthcare resources more effectively. So we have been very aggressive about helping people stay at home, helping them be healthy, and creating space within our systems. We need to continue that because if you go on the New York Times website, you can actually see a county-based doubling rate for the country. And if you look at Charlotte, a week ago, our doubling rate for cases was every 3.5 days. It's now every 7 days. But if you look at Buncombe County, it's every 2.5 days. So it's important that we stay vigilant, and it's important that we recognize this is going to go on for months because it's going to be hard, and we need to still do the little things right. Victoria Sutton, hey, Vicky. Big Sutton asked to explain a little bit about the layoffs and shortened hours. So what we see right now is that across the nation, what has historically happened is hospital volumes decreased dramatically in the lead up to the surge of COVID sick patients. So hospital volumes decrease because people aren't going to the hospital, people are canceling elective surgeries, hospitals are canceling elective surgeries, which is the appropriate thing to do. And then slowly you see a surge in COVID patients that are sicker and sicker and sicker that end up occupying hospital beds for a long time. That window of time, whether it's 2 weeks or 4 weeks or 6 weeks prior to hospitals getting filled up, you will start to see clinical practices closing down, elective surgeries closing down, ambulatory centers closing down or not seeing as many patients. And as a result, you in essence have hundreds of healthcare workers or support staff with nothing to do. They will have something to do most likely in 2.5 months, but there's a mix between availability of staff and the problem set now versus in a couple months. So it's a very complex problem. And in other places like Texas, what they've done is they've just said, we're going to fire people and lay them off. They can collect unemployment insurance. And then if we need them again, the unemployment rate in the country will be so high that we will not have any problem hiring people back. So we're going to cut our payroll because it saves us X amount of money in that time. So that's again, the sort of like dumb guy's understanding of the problem. Tawander saying, can you speak to the, sorry. Yeah, can you speak to the notion that African Americans are dying at a greater rate than other races? I can speak generally to that, and basically this goes back to the general concept of social determinants of health, which is not new and not new to COVID. What we know is that when you have things like health literacy problems, instability in housing, when you have disparities in the way healthcare is provided or health services are provided in general, whenever you have a shock to the system, the people that are affected by that more seeing the consequences more. Now there's some thought that there may be a connection to the rates of hypertension in the African American community compared to other communities. That may pan out, but I think, in my opinion, it has more to do with the fact that even prior to COVID, we saw higher morbidity in those communities as well because of the way our systems are designed. Tom Cox, what is the scenario for the next of the year? I'm not sure I understand. What is the scenario for the next of the year? I'm not sure I understand, Tom. I'll come back to it if you want to clarify that. Chase Saunders. Oh, for the rest. Sorry, Tom. What is the scenario for the rest of the year? So last Friday, and I'm just going to give a little history. Last Friday, all the models predicted a peak in North Carolina of April 14th with a significant overflow of all the healthcare systems and basically an overwhelming of healthcare systems. On Monday, that model, and you may have seen, this is what prompted the discussions about using UNCC as a field hospital. On Monday, literally 3 days later, all the models said that the peak is actually going to be in May, and it will not overwhelm the healthcare systems. And so I can't predict what will happen for the rest of the year. What I can tell you is that this will go on probably for 6 to 12 months, and we'll see the impact because we'll continue to see cases as people start to say we need to get back to work, we need to reopen the economy. I think what we'll see is additional spikes in the cases, and this is what's going to make it really challenging about how do we get back to an operational capacity within our healthcare systems. Chase, are you short of masks? Do you have a procurement office in which inquiries can be made? Yeah, yes is the answer on masks. I'm happy to connect with you offline. There are mechanisms to engage. It's pretty complex at the moment, though. Anonymous, what are your thoughts on cloth face masks for healthcare workers? So it's a good question. I'll maybe take it more broadly. The reason that you wear a face mask is to protect other people from you, is the main reason. The cloth face masks, the surgical masks, they do not do anything to prevent aerosolized COVID from getting in your system. They do two things. One is they prevent you, if you're sick, from coughing on other people. And then the second thing is they may prevent you from actually touching your face. And so that may get sick. Other than that, I don't think they do a ton. I'm all for it. I think that it helps with behavior modification, and if everyone does it, then it certainly decreases the risk of spread, because the people who are minimally symptomatic or asymptomatic who have a mask on are now not out spreading the disease. Anonymous, when do you think Mecklenburg County will peak, and when do you think the stay-at-home restrictions will be eased? The predictions for the peak are May 11th as of today. Again, that changes on a daily basis. When will the stay-at-home restrictions be eased? Probably not for a long time. I would refer you to the open source minutes from the county commission or council meetings over the last week. They talk about that, and the county has actually just proposed increasing some of the restrictions and extending them. We're building, Tawanda saying again, we're building face masks at Olympic High School. How can we get them to you guys? Just give me, LJ, Tawanda, I'll just, I don't know, my email is david.callaway, Callaway, at atriumhealth.org. So if you email me, I'll take any of the, I'll help you with that. Anonymous, do you expect any impact on schools in the fall or after Christmas break when the second wave? I don't know the answer. Yeah, so the question is, do you expect any impact on schools opening in the fall or after Christmas break when the second wave of COVID-19 is expected to hit? Yeah, I'm sorry, I don't know. Yes, I expect it, but I don't know what it will be, to be honest. Anonymous, again, do you expect, sorry. Are you able to speak to the comment that was made by Dr. Fauci that the COVID-19 virus will be a seasonal virus and will be something to deal with in the future? It very well may be. So the coronavirus family is what causes the common cold. The challenge with this particular novel coronavirus is twofold. One is it seems to be a little more infectious than the coronavirus that causes the common cold. And the other is that it hasn't been cycling in the human reservoir, so we don't have developed immunity to it. It emerged from an animal reservoir, and basically humans didn't have any immunity to it, and that's why we were seeing the high mortality. So I defer to Dr. Fauci. He's a really smart guy, way smarter than I am, and he is a person. When I talk about delete or like get rid of all the noise, if you want to listen to one person, listen to Fauci, because he is probably the smartest guy on this topic right now in America. Charlotte, can you speak, Klopp, can you speak to the perspective that these viruses seem to emanate from abroad? Why is that the case? What would your recommendations be for minimizing the impact if we were to face something similar, a similar health crisis down the road? These viruses emerge from basically what happens is they are endemic in an animal host, and then they mutate and they jump to a human host, and then they become a pandemic and spread around the world. So where we see this happen is anywhere where you have basically human-animal interfaces. And so the Wuhan market, we basically in China, we've seen the emergence of SARS and most of the flu-based diseases. Ebola keeps in Africa. Again, it's because wherever we see a human interface with animals in sort of an uncontrolled environment, that's where these diseases expand. I think that the way we minimize the impact is we choose to invest wisely in the systems in our government that are designed to address this. We take a broader approach to national security, and we say that, you know, our educational system is a key component of national security. Our ability to track and monitor disease is a key component to what makes us strong as a nation. We empower NIH and the CDC. We listen to our technocrats and our experts in our government, and we don't refer to them as the deep state. I mean, I think that we have a lot of smart people. We have a baseline structure for how we can address this problem. We as citizens need to demand that that we strengthen those systems, and then we as a country need to say it's a priority. And the fact, the like cold naked fact is that we have not. and we're reaping what we sowed. Millie Cox, what do you think of the idea of having those who are immune go back to work first? I think it's great. And I think as soon as they can figure out what level of immunity is generated after the infection, I think that becomes a real strategy. I also think the fact of the matter is, in many of these places, people who got sick probably need to go back before they are test negative, and care for other people with COVID. And the way you mitigate the risk for that is you make sure that everybody is wearing personal protective equipment, and everyone is doing good hand hygiene. And you know, it just, the fact is we may get to the point where a doctor who's infected with COVID may need to be taking care of COVID infected patients as well. John, the long-term impact is relying upon accurate testimony. Many people, how and when do you see that evolving? For the last, John, you're getting to one of my like favorite rants. For 6 weeks, I have asked this question: what is our national testing strategy? And I don't know the answer, but we need to have one. So there are a couple different ways you do it. One is you try as many people as you can to understand the prevalence in a community, and then you use that to target public health interventions. That's what South Korea did. That way you identify minimally symptomatic or asymptomatic people who are actually carrying and spreading the disease, and you give them things they can do to help stop spreading the disease. The other is that you use it when people are entering a healthcare system in order to cohort them so they don't spread the disease to other people. I am a strong believer that our testing system and how we've rolled it out has been completely inadequate and totally incoherent from a strategic standpoint. And so at this point, I don't know the answer. We have, dozens of different types of tests. We have fast-tracked some through the FDA. There are different sensitivities and specificities of the testing. Some come back in 45 minutes, some in 4 hours, some in 5 days. So when you have all of that variance, it's hard to create a coherent strategy. How can we continue to support the healthcare community? Stay at home. I think the way you support the healthcare community is help support your community. Be kind to each other. Stay at home. Wash your hands. Don't spread the disease. We love the innovation of some of the groups who are helping print 3D face shields. We love all of the. I mean, I can tell you that whoever started the initiative to write at all the hospitals in chalk on the sidewalks little notes of support to our staff. I mean, that stuff's great, and we're on the front lines because this is what we chose to do. We're doing it because we believe in our community, and so the biggest thing is to have a community that believes in itself, and that makes it worth it for us. Anonymous. You are very handsome. Oh, thank you, Anonymous. Just kidding. Anonymous number 2. At the outset of your comments, you mentioned that there was some preparatory steps taken towards combating a pandemic event, but we were not as prepared as we should have been. What do you think is on the horizon regarding a greater or worse attack, either real or promulgated? You guys, you can go download the 2005 pandemic plan, and if you read through it, it's comprehensive and it makes sense. We just we haven't funded it. Our national strategic stockpile has dwindled. We haven't put the good backbone of a public health system in place in the United States. One of the biggest challenges is public health is owned by the states and or the counties, which has some ease of operations. But the fact is, as we've seen, coronavirus doesn't care about the border with Mexico or the border between Oklahoma and Texas or between Mecklenburg and Buncombe County. I mean, we need a coherent national plan for responding to pandemics that's integrated into a global plan. And until we agree to that, and until we agree that that's a real priority, we're going to face things like this. And let's be honest, this is a cost-benefit trade-off. Someone has said, much like we sometimes see in business with the conflict between short-term quarterly reports for stockholders versus long-term health of a business, we have made the decision that we would rather have tax cuts and investment in other stuff in the short run than the ability to develop a robust public health system that can prevent this type of thing. We've just said we're gonna pay for it when it happens, and we'll deal with it at the time rather than coughing up the preventive piece of it. Stephanie Henricks, regarding tests, any update on the timing of antibody tests and when we expect that in Charlotte? No, I don't have any coherent thoughts on that, Stephanie. The IgM, IgG tests, it's evolving rapidly. I don't know when it will show up in Charlotte, and I don't know how we will integrate it into our plan when it does. John, how can we develop our own state or local test strategy? So the strategy requires infectious disease to articulate why we want to do something. And then it requires operations and logistics to make sure we have every single component of the test. So the swabs, the reagent, the testing machine. We then have to have the personnel that can go do the test. We have to have the back end way of tracking people who have the test done, whether they're positive or negative. And then it has to be integrated across the county and state public health as well as across the healthcare systems. So the answer is yes, we can. It takes somebody to step up and own the problem set basically on a state level. So it requires a healthcare executive, an insurance executive, and someone from the state to say, we're going to bring together a coalition, we're going to create our test strategy, and then we're going to, as a group, make sure that we have all the components necessary to do it. Melissa Ratliff, yeah, maybe. So how do we send thank you to healthcare workers? There are ways. I don't have the direct information right now, but thank you for the thoughts. Anonymous, what percentage of beds, ICU units, and ventilators in the Atrium system in North Carolina statewide are now devoted to COVID patients? Is hospitalized ICU ventilator use at Atrium at capacity or over capacity, or is there still room for a surge in COVID cases? Our focus right now is on surging our ICU capabilities and acquiring more ventilators to meet that surge. We are currently in the county, I'm going to speak broadly for the health systems. We are not at capacity for ICUs or ventilators. We have gone out and aggressively expanded potential ICU beds and acquired more ventilators. And in terms of COVID versus non-COVID patients, in essence, we've created a tiered cohorting plan. So if you can think about it, we have, for example, if we had 1,000 ICU beds at Atrium and we've expanded to near that, we would take 50 that are COVID, and then we'd add another 50, and we'd keep them separated from the rest of the ICU patients. And you keep building this cohorted fashion of ICUs, but it's a very complex problem set, and obviously I think is one of the major things that we're working on to help save people's lives. We've got a great team working on it right now. Dana Hicks, how many coronavirus testing locations does Atrium have in Metro Charlotte? What criteria is Atrium using for someone to get tested? The number of sites that we have varies. I think I'm going to give you a range, Dana, because I don't remember what today's update was, but somewhere between 8 and 12. The testing sites that we're using right now are all referral sites from primary care physicians, and the criteria that we're using is based on the CDC, a modified version of the CDC criteria, and the testing criteria literally change every day, if not twice a day. And part of this goes back to the prior question about the logistics of testing. When you don't have enough tests, you have to have strict criteria for who you test. And so as a country, we have not rolled out enough tests to create a coherent strategy. So each each health system, each state is creating slightly different criteria for who they test and why. And again, it's a very dynamic process that changes as we get more capability to do tests. Stephanie Henricks, are you able to share how many patients have survived the virus in Charlotte? I don't know the recovery numbers, I'm sorry. Aaron Harper just posted how you do arrangements for donations, community benefit at atriumhealth.org. Anonymous attendee, I've not seen any questions around vaccinations. Do you think that the rush to develop vaccinations will initially be effective in treating, preventing COVID-19, or do you think more time will be needed before an effective vaccine will be developed? I'm not an immunologist. I'm just a ground pounder ER doc, but I think it's going to be 12 months before we have an effective, 12 to 18 months is what I hear for an effective vaccine. But if you go along with Dr. Fauci's premise that this will be a cyclical disease, now that it's in the human reservoir, I think the vaccine will be important. All right, is that, oh, sorry. All right, sorry. Anonymous, I read recently that it is estimated that by the end of this phase of the pandemic, about 95 to 98% of the U.S. population will have had no exposure. Sorry. Well, estimated that by the end of this pandemic, about 95 to 98% of the U.S. population will have had no exposure to the coronavirus. Of course, we will need everyone to be tested for the coronavirus antibodies to know the exact number. Given the vast majority of the population do not have nor will not have immunity to the disease, how is it possible to reopen the country? Won't the virus start back and be spreading just as swiftly when we reopen? I have not heard that 95, 98% number. I've heard that the expectation is 40 to 60% will actually have contracted the disease, probably by the end of summer. And I think that's probably a more accurate number. So I haven't seen the 95, 98%. I think coronavirus has been here for months. I think probably a lot of people have had it. If you think about the fact that the first case was sort of announced at the end of December, and the amount of time it takes to actually diagnose a new disease and then sequence it, it was probably around in November. We didn't shut down travel for a couple months. And then it was only from China when we knew it had already spread to the rest of the world. So, my presumption is that coronavirus has actually been in Charlotte, or sorry, COVID-19 has probably been in Charlotte, North Carolina for 2 months. And we're only starting to see the sickness now. There's some data that shows from the time that you're exposed until the time that you actually end up in the hospital can be 3 to 4 weeks. That goes along. If it takes up to 14 days from the time you're exposed until the time you get symptomatic, and then the time from being symptomatic to the time to really getting sick is average 8 days. So that means it's 22 days from the time that you were first exposed until you're actually sick enough to go to the hospital. In that time, you're probably infectious at day 5 of exposure. So it's probably been around. All right, Anonymous, from your perspective, what do you believe to be the best way to support all the medical professionals in our community during these times, and what way would you like to receive support? What would be most beneficial to you? So, I'm going to give you one doctor's opinion. My opinion is that the biggest strain for physicians is not being able to come home and see our family, or how we deal with being quarantined from our family. I think the biggest stress in the healthcare system is to our hourly workers. So our secretaries, our healthcare techs, our nurses, our environmental service people, some of these individuals who make just above the sort of Charlotte living wage, and now they're losing hours. So I think that the way to support the health system is to make sure that within the health system, we're supporting the people who are on the front lines who don't have some of the buffer that other people have. And just like society, there are, there's a wide range within the healthcare system. We have lots of people who are living paycheck to paycheck. So I appreciate, and I know my colleagues appreciate all the well wishes for physicians, but I mean, there's so many people that are there that make healthcare happen, that are in the shadows and that are in the ways, those are the people that I really want to see get called out and supported. Why is South Carolina death rate proportionally much larger than North Carolina? Because they're not, well, one reason is because South Carolina is not taken as aggressive of a social distancing stance as North Carolina. So people are still out and about and the disease is spreading more rapidly. In terms of the mortality for the people who get it, I don't know that we've dug, someone may have dug into it, Wayne. I don't know on an individual level why South Carolinians may be dying at a higher rate. I know they're getting hospitalized more, and I know part of it has to do with the rapid doubling rate because they're not doing the same social distancing that we are. Jeff Waldrop, what is the most practical step to develop or focus on in the future to improve coordination between the National Incident Management System and the healthcare providers to prepare for and improve response to these similar situations? I mean, it's money, man. Like the systems are there. So Jeff is referring to the NIMS, National Incident Management System, and within that is the Incident Command, and that's basically the sort of operational structure for how we do disaster response. We've gutted funding for NIMS, we've gutted funding for the National Disaster Medical System over the last several years. The hurricane in Puerto Rico basically broke the National Disaster Medical System, which is what you all would know as like the DMAT teams. Because they couldn't stand up enough teams. They had to cycle them off. They went more or less expended their budget in personnel. So, I mean, one thing you do is you can create national security healthcare systems. And so this becomes a public-private partnership where a place like Atrium Health gets designated as a national security asset. And we're able to leverage some of our internal private sector capacity to support national response. You can find more nimble ways of engaging nonprofits. And again, full disclosure, I'm the chief medical officer for Team Rubicon, but you can take groups like the Red Cross or Team Rubicon, and you can figure out how to integrate them into the national response framework. As many of you probably know, the biggest challenge on a healthcare response system standpoint nationally is that the states own licensing and credentialing. So for example, I have a national board certification in emergency medicine, and it's the same everywhere in our country. It's a national certification, but I have to pay $300 to $1,000 in each state to get a license to practice in that state. That's true for virtual care and telemedicine as well. That dramatically limits the ability to respond across state borders in times of crisis, and it was one of the advantages of the National Incident Management System in NDMS. Now, what we've seen in the last couple of years, and I know we're running a little late, but governors have basically, a crisis hits and the governors are, in essence, waiving that credentialing and licensing requirement in an ad hoc fashion. What I would recommend is instead of just doing that in an ad hoc fashion, we figure out a way to do that on a day-to-day basis, and that allows us to build these strong relationships during blue skies that can allow us to respond more effectively during crisis. All right, I think LJ, I'm not sure there are more questions, but I know it's 3 o'clock. So I want to be respectful of people's time.
Thank you so very much, Dr. Callaway. Thank you, David. We did go a couple of minutes, but this is such an important topic. I'm extremely grateful for you taking time out of your busy schedule and joining us today and sharing all this knowledge and experience with us. We will reflect on what you have said. We will talk to you again. And again, thank you. Thank Atrium Health and everyone who's working so hard to diminish the effect of this deadly disease on our community and region. Everyone, thank you for participating in our first Digital World Affairs Council programming. We will have more of these programs. Please do follow our Wednesday update newsletter where we will announce upcoming programs. David, it was a great pleasure. Thank you once again. We're adjourned.
LJ, thank you very much. Thanks, everyone.
Bye-bye.